Thank you. I'm delighted to be here. The subject that we'll be talking about today is really depicted in a question that's implicit in these two photographs up here. Namely, if someone gave you this newborn infant with its extraordinary potential and said you had 18 or 20 years to develop it into this person lying unconscious on the sidewalk, overlooked by a world that's frightened of such things, how would you do that? That's really what we'll be talking about. So the implications of this are really widespread. I'll summarize what we learned in the ACE study first to give you a little bit of structure before we look at the data supporting this. The ACE study is the largest retrospective and prospective analysis ever carried out to examine the adult effects of 10 categories of adverse life experiences in childhood. 17,500 adults underwent comprehensive medical evaluation at the outset and then were followed for 20 years. The existence of adverse childhood experiences was found to be unexpectedly high and unrecognized because they're lost in time and further protected by shame and by secrecy and by social taboos against routinely exploring certain realms of human experience, such as incest, rape, etc. The existence the effect in adult medicine a half century later is powerful and proportionately related to the number of categories of adverse childhood experience. And they turn out to be a major determinant of adult well-being, health risks, mental illness, occupational performance, social malfunction, including imprisonment, biomedical disease, and premature death. So how did all of this begin? It really began in an obesity program where in the early 80s we started using a then new technology of supplemented absolute fasting, which allows one to take a person's weight down about 300 pounds a year. Now, we had no idea what we were doing at the time, but were in possession of a powerful technology. And in 1985, this woman came in weighing 408 pounds, asking us if we could help her with her problem. Our first mistake was in accepting her diagnosis of what the problem was. So we said yes and took her into the program, and in 51 weeks took her from 408 to 132. And thought, well, we've got this problem licked. This is going to be a world-famous department here. But she ended up teaching us that, as is the case with smoke and house fires, the smoke that is the most obvious manifestation of a house fire is not the essence of the problem. And we can only thank God that fire departments understand that. Otherwise, they'd be bringing big fans to treat house fires. Years later, we got this picture over here when she was 8 years old. And that kind of forces a question that we did not know enough to address at the beginning. You know, like, my God, what happened? What happened here? And why? So she taught us that age of onset is a key point in understanding obesity. Here's her weight curve. Looks kind of like an Olympic ski jump. 408 to 132. She stays down here for a couple of weeks, and then in one 3-week period regains 37 pounds, which I had not believed physiologically possible up to that point. And I remember asking her, you know, what's going on? I think I'm sleep eating. She said, well, what do you mean? Well, when I was a kid, I used to be a sleepwalker. I haven't done that for years, but I live alone. And when I go to bed at night, everything's clean and put away in the kitchen. I wake up in the morning, boxes and cans are open, pots and dishes are dirty, somebody's obviously been cooking and eating there. I'm the only person there. I guess that's what's happening, but I have no recollection of any of this. Okay, but why now? Why not 3 years from now or 2 years ago? Why now? And at that point, she said, well, actually, there was this man at work. He said to me, hey, you're looking pretty good. You lost all that weight, Patty. How about you and me making it every week? And that was the day the sleep eating began. And I remember thinking, well, it's a pretty crummy proposition, but this is 1986. It is Southern California. It's sort of an extreme response. You know, why the extreme response? And pursuing that in a few minutes led to her telling me that starting at age 11, her grandfather began routinely having vaginal intercourse with her for the next 10 years. And I remember naively thinking, wow, this is the second incest case I've seen in then 23 years of practice. Little did I know. In short order, she was back over 400 pounds faster than she had lost the weight and disappeared for 12 years. But another incest case in a few weeks led to my routinely asking patients in the obesity program about childhood sexual abuse. And I was floored because it seemed every other person was acknowledging that. And pretty soon, going down that trail, we started hearing about other things that had happened to people in childhood that we had never thought of asking about before. So here she is over the next year. She's back over 400 pounds again, back to safety. An important idea up here at top, that if obesity is not the core problem, then weight loss is not going to be the solution. So as I say, she disappeared for 12 years. 12 years later, she reappears, still safely over 400 pounds, and she unwisely decides to have bariatric surgery without dealing with any of the underlying issues. And at a point where she had lost only 94 pounds, which was not, the volumetric reduction was not clearly obvious, she became uncontrollably suicidal, had 5 psychiatric hospitalizations over the next year, and required 3 courses of electroshock before stabilizing. And 18 months after that, We spoke about why this occurred, and she clearly made the point that what we had seen as the problem was in fact for her a solution. Listen to what she says, because as we soon found out, this had applications far beyond obesity. Whoops.
I wasn't really handling the weight loss too well. I mean, it came off too quick, and I just felt like I was losing my protective wall. It was like, you were right, there was no going back. I wasn't able to use food as my way to get fat again, to have my solution back. It's like I had lost my solution, and I was having a hard time trying to find other solutions to deal with the underlying issues of the obesity versus just using the obesity as my wall.
Here's a man's view of things. He became obese as a child after his parents divorced, and he had to live with his violent alcoholic grandfather so his mother could work. And he vividly recalls eating for solace, as in our phrase, comfort food. And as he grew obese, he discovered that obesity offered advantages. As he speaks, think of our expression, throwing your weight around.
It wasn't that I ate because I was hungry. And it was, when I look at it, it was just a place for me to feel safe. As a child, I remember there was a point, I would probably say, all the way from kindergarten to, God, I don't know what grade, but I used to get beat up all the time. All the time. And when I got the weight on, didn't happen.
This woman was heavily molested as a child. She treated that by smoking 3 packs a day. And she was thin until she married, and at age 35, her husband convinced her to stop smoking. Suddenly she's faced with the problem she had no experience with, which made her very anxious. She was flooded with male sexual attention. And she explained to me, when you smoke 3 packs a day, there's a cloud around you that keeps people at a certain distance. She didn't know how to deal with this. She started eating to feel better. As she put on weight, she noticed that reduced the sexual attention. And that was pretty much resolved when she got up to 310 pounds from her prior 130. But at 310, the lung damage that was present from smoking 3 packs a day was no longer tolerable, whereas it had been tolerable at 130. And she had to go on 24-hour-a-day oxygen. So some years later, she comes into the program, and we take her from 310 to 150. We still hadn't figured out exactly what we're doing. And again, when we saw she no longer needed the oxygen, wow, I mean, what a big success we've done here. But again, she is flooded with male sexual attention, and she consciously makes the decision to get back over 300 pounds and accept the fact that she's going to be on 24-hour-a-day oxygen for the rest of her life. Listen to what she has to say, because she says something extremely important. Oops. You supplied me recently a lengthy autobiography, a number of dozens of pages altogether. And on the very next to the last line, you said something that I thought was extraordinary. Let me read it to you, because I think it's remarkable. I believe smoking 3 packs a day and weighing 300 pounds are not the problem. They're the symptom. Took us a long time to figure that out here, and you just casually drop that as though, of course, anyone knows that. In case you didn't hear that clearly, what she said was, I believe that weighing 300 pounds and smoking 3 packs a day are not the problem. They're the symptom of the problem. That's a very impressive idea. And when I heard her say that, I remember thinking, I wish I had met you 50 years ago. You'd have made my career a great deal easier. She helped us realize that we were recurrently facing a public health paradox, namely that many of our most common and intractable public health problems are indeed that, from a social standpoint. But from the individual's standpoint, are often unconsciously attempted solutions to personal experiences that occurred in childhood and that have become lost in time, and then further concealed by shame and by secrecy and by social taboos against exploring certain problems. So this was a coping device, an unconscious treatment for problems that we've all been taught as children nice people don't talk about, and hence that we don't understand. And ultimately the question arose, how common are these adverse childhood experiences in a general population, and how do they play out other than as obesity? And that led to our collaboration with the CDC to determine the answer. One of the key things that we learned was that a major portion of medical problems in adults are an outgrowth of life experiences in childhood. The A study involved 17,500 people, basically like you and me, almost exactly half women, half men, average age 57, 80% white, including Hispanic, 10% black, 10% Asian, 74% had been to college, a clearly middle-class population. And they were coming through this unusual Department of Preventive Medicine we had, where 58,000 adults a year came through for comprehensive medical evaluation. So here we are determining adult health status and medical status at average age 57, and going back roughly a half a century to compare that with 10 categories of adverse life experience in childhood, and I'll define those momentarily. And then we followed them for 20 years to see how what happened back here 50, 60, 70 years ago played out now in terms of pharmacy costs, ER visits, doctor office visits, hospitalizations, and death. The 10 categories that we studied were selected simply because they were the 10 most common categories that showed up in our obesity program. They're not the only 10 in the world. And if you had a population that consisted heavily of immigrants from some war-torn corner of the earth, some of these might be replaced by others. But in a population like you and me, here's what we had. Major emotional abuse, basically recurrent humiliation, acknowledged by 11%. This is in a general population now. Major physical abuse, I don't mean spanking, I mean beating with fists and sticks and other objects, 28%. Contact sexual abuse, 28% for women, 16% for men, 22% average for the group. Major emotional neglect, major physical neglect. Growing up in a home where one of the members of your household was an alcoholic or a drug user, 27%. Growing up without both biological parents, 23%. And that was interesting because it soon became clear that if you're going to lose a parent, the best way, the least damaging way, was by death, unless that death was a suicide, because death at least offered the potential of creating a protective mythology. My father would have protected me if, my mother would have cared for me if. Most destructive, really overwhelmingly, was maternal abandonment. Mom split when we were 3 and we never saw her again. Growing up in a home where one of the members of your household was chronically depressed, suicidal, mentally ill, in a state hospital, 17%. In a household where mother was treated violently, 13%. In a household where one of the members was imprisoned during your childhood or adolescence, 5%. We were dealing with mountains of information. We needed a way of simplifying things and decided to create an ACE score, which was the sum of the number of categories, of adverse categories, not events, but categories. And we did that because we figured that people were going to be so disturbed by this information, they'd try to make it go away. Come on, you're trying to tell me that somebody 50 years later remembers they were molested 13 times and not 10? Data's no good. I mean, get rid of this stuff. So the ACE score is the sum of the number of categories. And what we found was, in a general population, 33% claimed none of those 10, obviously 67% one or more of the categories. 1 in 9 people, 5 or more of the categories. And we saw that women are 50% more likely than men to have an ACE score of 5 or more. But what does this look like in the office? Well, here's a good example. A bright guy. He is an alcoholic, a 3-pack-a-day smoker, and a heavy user of crystal meth. The backstory, which most people would never know, which we learn by routinely asking. The backstory is that when he was 2, his parents divorced. He never saw his father again. When he was 5, his mother remarried. For whatever reason, his stepfather saw fit to beat him pretty much every day. When he's 8, he remembers going to school one morning and the thought crossing his mind, nobody is ever going to be there for me in my life. When he's 20, he comes home one day, finds his stepfather beating his mother. He takes a heavy cast iron frying pan and fractures his skull, and impressively also produces 5 long bone fractures. He's imprisoned in Rhode Island for a number of years for attempted murder. Ultimately, he gets out. Listen to what he has to say about the benefits of nicotine and other substances that are overlooked in public health. The benefits, not the risks. The risks are very real. The benefits.
225 years drowning out some poor childhood experiences with drugs, alcohol, cigarettes. Gotten rid of the drugs, got rid of the alcohol. Next thing I got to get rid of is the cigarettes. And I had no idea that the nicotine played such an important part in keeping that door closed.
In keeping the door closed to?
The memories that I've blocked out with all these years with the alcohol and the drugs.
So you see what's happening to you now as related to what happened to you decades ago?
Yep. I found a way to block the emotions and the memories.
With?
Drugs, alcohol, cigarettes.
So he's talking about the functionality of what we dismiss as dysfunctional behavior. He's a heavy user of crystal meth. Everybody knows how bad crystal meth is. Virtually no one knows that in the early 1940s, methamphetamine was the first really successful prescription antidepressant on the American market. Here's a full-page ad from a 1943 issue of the Journal of the American Medical Association. But isn't it dangerous? Well, if you don't understand dosage, pretty much any medicine can be dangerous. If you double your digitalis dose, you'll be dead in 10 days. Take 30 aspirins instead of 2, you've taken a suicidal dose. We looked at how ACE score relates to self-acknowledged chronic depression. And here you see women in red, men in yellow, a very clear dose-response curve. As the ACE score goes up, the probability of self-acknowledged chronic depression goes up. Remember, we're looking now at current experience and comparing it to what happened roughly a half century earlier. We look at suicide attempts. Oh, wow, I mean, this is really strong. So strong that we can't fit ACE score 6 on the graph because ACE score 6 is so far off the graph that it compresses the rest of this to illegibility if you try to fit it on. At ACE score 6, the likelihood of attempting suicide later in life is 3,100 to 5,000% higher than at ACE score 0. Interestingly, this turns out to have a significant relevance to an all-volunteer army. Some years ago, I was on a government committee put together to look at why there was such a high rate of PTSD in Gulf War I, where there was only 170 hours of ground combat. Gulf War I was all aerial bombardment. So, I mean, where's all this PTSD coming from when there's no cause, no explanation? Well, it occurred to me that Gulf War I was the first time an all-volunteer army had been put into the field. And I remembered from my own time as an army doctor years ago that the army was really a wonderful metaphor for support of family, particularly if you didn't have one. And the thought crossed my mind, could it be that now that we're no longer sampling the entire population, that we've essentially created a magnet to attract people who are looking for this metaphor? Some years later, I ran across an article that General Shinseki had written expressing concern about the high rate of suicide in military recruits, not guys coming back from the combat zone, in recruits. So I wrote to him about this idea. He passed it on to the psychiatric consultant for the Army at that time. And Colonel Orman decided that he would put the ACE study into play at Fort Hood, Texas, a huge infantry training center, use it with all of the incoming recruits. Well, we were thrilled at this opportunity to learn more. 2.5 months into this, he decides that he has to temporarily stop because the drill instructors, you know, the caricature tough guys, the drill instructors cannot handle the number of recruits who are breaking down crying, filling out the ACE study questionnaire. Orman's idea was that he'd figure out what to do to put the drill instructors back together again and reinstitute the program. Unfortunately, his wife developed cerebral metastases at that point, and so the whole thing fell into abeyance. But it was a remarkable insight into a totally new idea. Here we're looking at the relationship of IV drug use to underlying ACE score. And again, ACE score 6 doesn't fit on. At ACE score 6, there is a 4,600% likelihood, greater likelihood than at ACE score 0 of that person becoming an IV drug user. And I remember the epidemiologists at CDC telling me that those are numbers, the magnitude of which they see once in a career. We looked at high-level promiscuity, same relationship. This might be better titled Looking for Love. Maybe the next woman or man is the one who's going to love me, and if not, well, surely the one after that. And sometimes when relating to one's peers is too threatening, that hope will be fulfilled by photos or a child or farm animal. We looked at biomedical disease. Pretty much everybody has some understanding that the Framingham study discovered the risk factors underlying coronary artery disease, heart disease, smoking, cholesterol, high blood pressure, diabetes, etc. There are 13 that they found. Most people don't know that about 12% of people with coronary disease don't have any of those risk factors. Well, how do they get it then? Well, we looked at that 12% and matched it against underlying ACE score and saw, again, this distinct relationship. How does that happen? Well, it turns out that under conditions of traumatic stress, where the brain is continually hyperstimulated by old recollections, be they conscious or unconscious, certain areas of the brain are hyperstimulated that cause the release of pro-inflammatory chemicals. And when these pro-inflammatory chemicals get to really small, microscopic blood vessels, they shut them down completely, turning to scar tissue, whatever piece of organ they had been supplying. Our first patient, Patty, never a smoker, no exposure to air pollution. Patty died at age 42 of primary pulmonary fibrosis. Her lungs had turned to scar tissue. In recent years, it's become evident that a certain portion of cases of this disease are related to these pro-inflammatory chemicals. In larger vessels, the inflammation of their linings has a magnetic effect on cholesterol as it flows by, regardless of whether the cholesterol level is low or high. Isn't that interesting? Well, you all know statins, the medicines that lower cholesterol and reduce the risk of heart disease, work by lowering cholesterol. And they do. But in recent years, it's become clear that the main effect of statins is not by lowering cholesterol. They do that, and that's useful. But the main effect of statins is by an anti-inflammatory effect that they have on the lining of blood vessels. Isn't that interesting? Let's move on to cancer. We found a distinct relationship of A-score to cancer, and our initial thought was, well, yeah, you smoke 3 packs a day to feel better, of course. And that's true, but that's not more than a small piece of the explanation. This woman is doing well, has a significant job in a major university, just the kind of person from whom we'd not seek an abusive childhood history. Of course, we'd skip such a history for our own comfort, but we'd be smart enough to say that we saw no need to risk upsetting a patient who's doing so well. So listen to what she has to say about cancer being related to her long incest history. I once would have totally dismissed that idea, but we'll talk in a moment about what's known to explain the validity of that idea.
Can you tell just by looking at me that I was an abused child? Can you tell that I was sexually abused routinely, that I was neglected, starved, beaten? Probably not. You would have to ask in order to find out, and that's not the sort of thing that people typically ask about. The downside of having this kind of childhood is that it translates into health problems in adulthood. At least in my situation, it seems to have done. I'm now recovering from my 3rd battle with cancer. Not the same cancer, 3 different kinds of cancer. I've had chronic pelvic pain, migraines, the whole laundry list of medical complaints, all of those sorts of things that are very difficult for physicians to figure out. Growing up that way instills a constant fear, a constant state of turmoil that's just under the surface of a veneer that's fairly thin. Little things become scary in an atmosphere like that, and once you've internalized all of that, it's very difficult to let go of it.
So how does this work? How does sexual abuse of a little girl lead to cancer? 50 years later, 3 different kinds of cancer. Never a smoker, lung cancer was not an issue. Well, we've known the explanation for some time, actually, but just never put the pieces together. We all know that if you get an organ transplant, you have to be on lifetime immunosuppression so you don't reject the organ. Some of us will correctly have heard that one of the side effects of lifetime immunosuppression is an increased risk of cancer. That's because all of us every day are forming small numbers of cancer cells from a wide range of organs, and our immune system recognizes them and destroys them, and we never know the difference. So getting cancer means either that something is massively increasing the rate of production of cancer cells beyond what our immune systems can come close to handling, or our immune systems are suppressed so they can't handle even the very low level of normal production of cancer cells. So that's really kind of an interesting insight. But here's an even stronger case. This is a quite remarkable autobiography. You can sample it on Amazon. This is the autobiography of a woman very successful in her life, who extensively the victim of her father, who had vaginal intercourse with her for about a decade. Worse yet, used to bring her into saloons at night and sell her to strangers for sex. Somehow she did not commit suicide. She did not become a mass murderer. She graduated high school. She gets a scholarship to college, graduates college. She gets a scholarship to law school, graduates law school, and ultimately becomes a United States federal judge. I mean, that's a big deal. And it would be very easy to say, well, isn't it wonderful that that poor little girl with that hideous history is so resilient? That shows the weakness of the way we conceptualize resilience. We base it on income, social success, academic success, etc. We don't look at biomedical outcomes. She has had 5 different kinds of cancer, and she has 2 autoimmune diseases. She has lupus and multiple sclerosis. We looked at 21 different autoimmune diseases to see if they had any relationship to A-score, and amazingly, we found a distinct dose-response effect to 16 of them. So this is really rather remarkable. Ultimately, we realize that adverse childhood experiences determine the likelihood of the 10 most common causes of death in the United States. And the risk factors underlying the 10 most common causes of death in the United States are the very things we've been talking about all along. With an A-score of 4 or more, the majority of adults have multiple risk factors for these diseases, or have the diseases themselves, or have died early. And with our 20-year follow-up, we found that at ACE score 6 or higher, there was a 19.7-year shortening of life expectancy, almost a 20-year loss at ACE score 6 or higher. So we realized that many chronic diseases of adults are determined decades earlier in childhood, not by diseases in childhood, as was once the case, but by life experiences. This is really a profound change in the past century. I mean, you think about it, rheumatic fever is gone, polio is gone, diphtheria is gone, smallpox is gone, rickets and pellagra? Most people have never even heard the word nowadays. Yet it was a scourge in poor areas of the country a century ago. The risk factors from the ACE study translate into adult disease by 3 different pathways. And this is an important insight into how we treat drug addiction, smoking, obesity, alcoholism, promiscuity, violence. It's hard to give up something that almost works, particularly at the request of somebody who has no idea what's going on. The conversion of ACEs into disease later in life is by 3 mechanisms. The long-term effects of various coping mechanisms that are used because of their short-term benefits. Again, smoking is a good example. Nicotine, within 15 to 20 seconds of inhalation, has distinct anti-anxiety activity. Its risks are major, but they're 15 or 20 years away. I think it's easy to understand, the screws are on tight enough. Give me that pack of smokes now. We'll worry about 20 years from now next week when things quiet down. So the long-term effects of coping mechanisms that are beneficial in the short term, smoking, overeating, inactivity, alcoholism, illicit drug use, promiscuity, etc. Then by the complex effects of major unrelieved stress that we were talking about before, and its effects on the brain as the brain control of immune function and release of pro-inflammatory chemicals becomes abnormal. And there's a third category that's not part of the ACE study. When we put the ACE study together in the early 90s, this word barely existed. The field has grown explosively since then, and we'll no doubt hear a great deal about it in the next few years. Epigenetic effects. The typical genetic effect that we're all familiar with is mutation, which is a structural change in a gene, often destroying the function of the gene, sometimes changing it in an occasionally useful way, but a structural change in the gene. Epigenetics refers to a chemical addition onto a tail of the gene that acts like an on-off switch. It turns the function of the gene on or off without affecting the structure of the gene at all. Keep the word in mind, because you'll be hearing a lot more about it. So, we saw that adverse childhood experiences are the main cause of health risk behaviors, and hence of disease and disability, premature death, healthcare costs. And whereas the Framingham study was of great importance in showing us that there were predictive risk factors underlying heart disease, in the ACE study, we found the determinants underlying the risk factors and saw that most of the determinants took place in childhood. And then one can wonder, well, why are these things so damnably difficult to treat? Here's an answer. These are PET scans of the brains of 2 3-year-old little boys. PET scan is a very sophisticated kind of X-ray depicting biochemical activity in color. On the left is the normal control, a 3-year-old little American boy. On the right, 3-year-old little boy taken from a Romanian orphanage some years ago. You may remember Romanian orphanages were discovered to impose extraordinary levels of neglect on the inmates. And what you see is large areas of brain where there's no color, where there's no biochemical activity. But I don't think it's going to tax anyone's imagination too much to think that maybe at age 3, when brain is still being formed, that this lack of biochemical activity is going to affect the kind of brain that's being formed. In other words, we're looking at the translation of life experience into neuroanatomy, and maybe that's why it's so difficult to deal with. So here's a summary of the ACE study. You have this very large base of people with adverse childhood experiences, overwhelmingly unrecognized, producing disruptions in brain development, producing various kinds of impairment early in life. This may be the socially isolated kid, the weepy kid, the one who has trouble learning in school. By the time they become teenagers, they have enough freedom to try to find something that helps. Alcohol helps, nicotine helps, tobacco helps, buying antidepressants on the street helps, sex helps. And those things that help in the short term, often when heavily used, end up producing disease, disability, and social problems. A lot of people die early. And the whole sequence is unrecognized, partly because it's lost in time, partly because it's protected by shame and by secrecy, and by social factors against exploring certain kinds of human malfunction. So how might we get from where we are now to where we could be someday? Well, 3 things seem clear. One would be to understand that these problems are common. That's overwhelmingly not recognized. Routinely identify cases in clinical practice, routinely not done at present. And most important, rather than trying to deal with these after the fact, to figure out how to prevent them in the first place, so-called primary prevention. I believe that would be through helping huge portions of the population, like 30, 40 million young adults, understand what supportive parenting looks like and how it plays out decades later. My personal belief is that if we could figure out how to do that, that would probably be the biggest public health advance of the 21st century. One of the problems with using this information is that none of us are initially going to be comfortable raising these questions with patients. But we've had some early and significant experience with integrating these findings into medical practice. First step of our comprehensive medical evaluation is filling out at home, important, not in the waiting room, at home, a very lengthy 10-page medical history questionnaire. We bring that in at visit 1. It's fed into a digital scanner that picks up all the yes answers, gives us a nice printout. So here's a little piece of the questionnaire. Questions like, do you sometimes drink more than you think is good for you? Yes, no. Do you use street drugs? Have you ever been raped or sexually molested as a child? Been physically abused, etc.? My colleagues assured me that I was crazy to ask these questions. You know, patients are going to be furious and nobody's going to tell you the truth. Well, we have used them now in a multi-year period with 440,000 adults and had 0 patient complaint. Asking everyone routinely, matters a great deal. Here's a real response sheet from the patient after it went through the scanner. This woman says she's been physically abused as a child, verbally abused as a child, sexually molested as a child or adolescent, been threatened by a sexual partner, wants to be tested for AIDS, has not been sexually active any longer, often feels hopeless or down in the dumps, etc. It takes 2 minutes, 3 minutes to read this before meeting a person. And what we do then is very important to understand. So remember this. Our most common approach has been to say to a patient in the exam room, I see on the questionnaire that. Can you tell me how that's affected you later in your life? And we listened, period. No humbug about, oh, that's so terrible, I'm so sorry to hear that, that must have been. We listened, period. We did one other thing, but it took us a while to realize that. We implicitly accepted that person. And this approach was a major advance, and its effect was totally unexpected and profound. After we're doing this for a couple of years, everything's going smoothly, a mathematician from the University of California comes by. This guy has a startup data mining company that now is on the New York Stock Exchange, and he offers as a gift to do a 130,000 patient study to see whether the addition of these questions has any effect. That was 2.5 years throughput for the department. And incredibly, he finds that it triggered a 35% reduction in doctor office visits in the next year compared to their year before, and an 11% reduction in emergency room visits. This has multi-billion-dollar implications for state Medicaid budget, for a huge system like the VA, for a huge system like Kaiser Permanente. Amazingly, it has gone nowhere so far. So let me close this way. We found that routinely incorporating adverse childhood experiences as part of comprehensive medical evaluation of adults is acceptable to patients, is affordable to us, and powerfully beneficial. That it's possible to move from our current symptom-reactive mode of practice and start dealing with basic causes and thereby improve care while markedly reducing its costs, and that a trauma-oriented comprehensive medical history has been demonstrated to have major benefits and is proposed as the routine entry mechanism into all ongoing care, whether it's medical, psychological, or institutional, including prisons. It's important to realize that there are only 3 sources of diagnostic information in all of medicine: patient history, physical examination, laboratory studies. If you ask patients, they assume that diagnosis comes out of lab tests. Oh, I want all the blood tests, doctor. Yeah, right. You don't have enough blood in your body for all the blood tests. If you ask experienced physicians, they'll tell you that about 75% of the time, diagnosis comes from patient history. The problem with that is it's time-consuming and hence costly, experience-dependent, fraught with interpersonal difficulties. Well, this doctor's too young to, no, this one's too old to understand. I'd rather talk to a lady doctor. I'd rather talk to somebody who's Polish or Korean like me that would understand me. The medical history, and as we found, including adverse childhood experiences, is an enormously powerful tool. So, summarizing, adverse childhood experiences are common and overwhelmingly unrecognized. Their link to major problems later in life is strong, proportionate, and makes sense. They turn out to be the nation's most basic public health problem. That it's comforting to mistake intermediary mechanism for basic cause. Oh, the reason that kid's fat is because there's a McDonald's in town. That what presents as the problem may be a patient's attempted solution, and treating their solution may be threatening and cause people to flee treatment, and that primary prevention is presently the only realistic population approach. We don't know how to do that yet, but it's the right question to focus on. And the change has been resisted by us in spite of enormous benefits. If you want further information, here are some sources. If you simply search ACE study on the internet and YouTube, you'll be amazed how much you download. And the rest of it, you can look up and take advantage of. There's a huge amount of information that's available. Thank you for inviting me. I hope that you all are able to do something useful with this information. A great deal remains to be done, but we've obviously stumbled into something of major significance. So I wish you well in your work and in your lives.